Hello everybody and welcome along to our PCC4U Educator Webinar. We are hosting the webinar session today from QUT in Brisbane or Meanjin, which is on Turrbal and Yagara country, and we're just going to play a short acknowledgement to country video now.
QUT acknowledges the First Nations owners of the lands on where we gather today and pay our respects to the elders, laws, customs and creation spirits of this country. For thousands of years, the First Nations owners have gathered to share their knowledge and stories. We pay our respects to all Aboriginal and Torres Strait Islander peoples and acknowledge the important role they play within our communities. We recognise their long and continuing connection to country, the lands, winds and waters throughout Australia. We recognise that these lands have always been places of teaching, researching and learning.
And it's my very great privilege to introduce Madeline German to you. She's going to be presenting on some of the work that she's been involved in, I'm sure over many thousands of hours of work, looking into this topic of the role of paramedics in providing palliative and end-of-life care. So thank you, Madeline.
Thanks for the introduction, Sharon. My name's Madeline Yerman. I'm a PhD candidate at the University of Sydney, where I'm looking into the role of paramedics providing palliative and end-of-life care in Australian communities. My supervisors are Professor Josephine Clayton and Professor Phyllis Buteau. So a little bit about me. I've got a background in paramedicine. I studied at Flinders Uni, and while I was a student there, I was also working in a residential aged care home. And it was through both of these experiences that I really identified the lack of skill, scope and experience that paramedics had in providing palliative and end-of-life care, despite the fact that we were so often seeing these patients and facilitating this approach to care. So that ultimately motivated me to undertake a master's in public health and then more recently start my PhD in this area. So I'll just introduce this quote to begin my talk today, but this is one that we captured in our qualitative study that I'll tell you about, but I think it really depicts exactly what I'm going to be talking about today. The idea that palliative care isn't necessarily perceived as a role of a paramedic. So summary of my PhD, it's 4 studies. I've done a systematic integrative review at the very beginning. I also did a clinical practice guideline review. I've just undertaken 50 interviews, qualitative interviews, and we're going to be finishing off with a Modified-Delphi study. And underpinning all of that, I've created an advisory group with cross-jurisdictional representation. Now, the expected contribution of my studies is to develop a palliative paramedicine framework that will be suitable for national implementation. But within that, we are hoping to achieve 5 main objectives. Firstly, in enhancing out-of-hours care, reducing avoidable hospital admissions, facilitating more home-based deaths, improving end-of-life care for people living with life-limiting illnesses, and building a community of palliative paramedicine practice. As I said, I've created an advisory group. Now, the main objective of this was to strengthen and promote collaboration between ambulance services on matters related to palliative paramedicine, to also advise on current operational barriers and developments specific to this provision of care, to inform studies to be carried out in the context of the PhD, including co-investigation by all of these members and co-authorship on studies, and also to drive the translation of evidence into practice in real time, not when I finish the PhD down the track. So I've just acknowledged all of the people mentioned on this slide and thank them for all of their contributions to date. So as I said, I started off with a systematic integrative review that was published in Palliative Medicine Journal just last year. Now, why a systematic review? When I was beginning this in 2020, there was literature on the topic, but nothing summarising or synthesising all of the studies to date. As we know, there's an increasing global demand for palliative care, and providing it in exclusively hospital-based settings by specialists is unsustainable. And there is also a increasing community preference for people to die at home. Paramedics I think that they are the unharnessed asset of palliative and end-of-life care in community-based settings, especially after hours and in regional, rural, remote areas where other services may be unavailable or restricted in their availability. But we know that paramedics are traditionally perceived as maybe not responding to palliative or end-of-life care emergencies. And instead, when you speak to someone about paramedics, you think the community's general response is a car accident or a heart attack or a baby being delivered in the back of an ambulance on the way to hospital. So we undertook this study to really synthesize the empirical evidence regarding palliative and end-of-life care delivered by paramedics in community-based settings. Now, we had over 20 articles that we included. We did a mixed methods review, so we didn't have just exclusively quantitative or qualitative studies. We had a real collection. And that was allowed us to do a thematic analysis, and then in turn with the themes that we derived, ensure that they were being backed up by the quantitative studies. And with that, we derived 3 main themes. Firstly, broadening the traditional role. Now that resulted around thinking beyond hospital-oriented care and allowing patients to have a natural death, which also raised questions around time on scene. Should paramedics be able to stay longer, or do they need to go to the next emergency? There was a lot of discussion within the included studies around strengthening communication and support channels with multidisciplinary teams. But palliative care provided a real professional satisfaction for the participants, particularly the paramedics. But there was training and education lacking, and perhaps that was due to the traditional perception of what a paramedic should do versus what they actually do. Now, understanding patient wishes was the next theme, and that was really surrounding about the documentation and availability or accessibility to those documents. Advocacy, paramedics advocating on behalf of their patients or the family members, and also the topics around patients lacking capacity and what to do then. Finally, supporting families. Now, as we know, in palliative and end-of-life care, the family becomes the patient as well. And this was significantly evident across the studies that we included. There was a lot of discussion around family discordance. So one family member wanting them to go to hospital, the other wanting them to stay at home. But the opportunities to partner in care with families to ensure that the best outcomes are achieved for the patient and the family as well. Family witness to arrests and the bereavement associated with that was a really interesting topic that arose. And finally, death literacy, meaning how do the patients and the family members understand death and dying, and how can we improve that to facilitate better palliative and end-of-life care in the future? The implications of this review basically was just describing the scope, barriers, facilitators and perspectives, and giving me opportunity to basically argue for these gaps and how we can improve them. It did support an expansion of paramedic practice beyond the traditional scope, and that's exactly what this webinar is on today. And I think that one of the main key takeaways for me was the recognition that this is a multidisciplinary practice or area of medicine that does require paramedics, but also the ability for paramedics to work with other teams despite their traditionally autonomous function within the health system. And it also identified clinical practice guidelines as key enablers to standardising practice and minimising legal complexities. So that brought us on to our next study, which we did, was just being published actually last week, and I'll share the links in the chat after this, also in palliative medicine. Now, we undertook a guideline analysis to examine the quality and the content of the existing guidelines within Australia, as well as comparable Anglo-American ambulance services. So those are ambulance services where it's paramedics rather than doctors in the ambulance. We used 2 approaches here. We firstly analysed or critically appraised the methodological rigour of the guidelines, and that was using the validated AGREE instrument. And then the second component of this study was to analyse the actual content of the guidelines and critically compare them across all of the included guidelines. Now, I think this stat really actually speaks volumes to the purpose and the justification for why we're doing what we are today. Of all of the jurisdictions in Australia, only 5 ambulance services have existing clinical practice guidelines related to palliative and end-of-life care. There's 1 national New Zealand guideline, 1 national UK guideline, and a Canadian guideline of best practice that we use to compare across here. We had an international team of multidisciplinary professionals with experience and expertise in this area. And I think it was 4 or 5 of them were from our advisory group. The implications of this review suggested that paramedics were shifting away from that traditional perception of protocol-driven practice, and we're moving to broader clinical models which require the discretion and decision-making skills as opposed to fixed algorithms. And that is really, I think, reflective of also palliative and end-of-life care. No one fits into a box, a clean, nice box in this type of care. It also identified the prevalence of clinical backup pathways, which I think indicates the evolving or emerging state of this area of practice for paramedics. And it really also underscored the importance of multidisciplinary approaches to care. There was an overall lack of content related to care after death, which underscores a significant gap in clinical practice. There are also a lot of our guidelines scored really poorly on the AGREE instrument, indicating that they had poor methodological rigor when it came to their development. So there's opportunities to create new guidelines or guidelines in those areas, those jurisdictions that have not yet got one, based upon these findings. And I'm delighted to say that already prior to the release of this publication, one jurisdiction within Australia has already translated these findings into their practice reflected in their guideline. So that is really the strength of having an advisory group engaged in this research. Now, in terms of future practice and future research, we identified the need to translate the specialist capacity of community paramedics into a generalist workforce as well, and also recognising that we should gain broader perspectives to help influence future practice. So that led us to our third study, which is qualitative interviews. As I mentioned earlier, we've just completed 50 interviews with a broad range of participant groups, including paramedics, palliative care doctors, palliative care nurses, GPs, residential aged care nurses, as well as bereaved family members and carers. And we really we were seeking to elicit the experiences and perspectives of these participants regarding the role of paramedics, the experiences around the barriers and enablers of the practice, and how we can improve that practice going ahead. Here's a quote that I think really captures the sentiment around the power and the opportunity for paramedics to be able to contribute to palliative and end-of-life care in a multidisciplinary approach. So these are the preliminary findings. So I'll note that they're not published yet. So if we could, they're certainly happy for people to see that, but maybe not disseminating across your networks. But we're going to do 2 papers. The first is going to be looking at the roles, the barriers and enablers of practice. And then the second one is going to be looking at opportunities for improving practice. Now, the first paper here, the findings really suggested that the rationale for objecting or endorsing a palliative approach to paramedicine it influenced the individual's perception of the barriers, enablers and opportunities for improving practice. And there were 2 dichotomies of thought. Now, they weren't binary. They weren't, you either had this thought or that, but they were very clearly apparent. And the first was lifesavers, or this idea that paramedics should stick to their job, and that is to respond to emergencies and treating in a curative focus to preserve life. And then on the other side, there were participants expressing a view that the paramedic role is evolving in response to the diverse needs of communities, and that does include an increased demand for community-based palliative and end-of-life care amongst chronic disease and management and illness. And both of those dichotomies of thoughts are influenced by 4 major sub-themes. Firstly, that paramedics have a revered public identity and they're able to fix a crisis. Secondly, paramedics often are afraid of palliative and end-of-life care and they feel vulnerable taking this approach. Third, paramedics, they require consent to move beyond their traditional scope of practice. And finally, paramedics offer an adjunct support for community-based palliative care. Our second paper, which is going to be looking at interventions or solutions to improving practice, we've broken that down into the suggestions put forward by our participants on a macro, meso and micro level. So macro meaning systems-based, meso meaning more services and community-based, and then micro meaning individuals, be it the clinicians or the consumers, the patients and their family members and carers. I won't go into the details about that, but I'm more than happy to answer any questions at the end. Our final study, as I said, main objective of my PhD is to actually develop a palliative paramedicine framework suitable for national implementation. I want to be able to standardise a minimum best practice level. Now, that doesn't mean that I'm saying that every ambulance service is fit together in a nice, neat box. We recognise that there are jurisdictional differences, as there are within a service differences. But I think that mandating or putting forward a suggestion of a national framework that can recognise the important structural, service, community and individual levels that contribute to improving practice would be in the best interests of all. So we've got, again, another multidisciplinary team on board for this one, and we're going to do this study at the start of next year. We'll be inviting participants from a range of areas as listed on this slide to participate, and we'll be gaining consensus on the components of the framework that they consider most essential for improving practice, and then we'll elicit recommended strategies to underscore the implementation of that framework. That's all from me, but thank you for listening, and I hope this was informative.
Thanks so much, Madeline. We do have some time for questions.
One of the points that you made, Madeline, was around the deficit in care after death was identified. Do you find that that's are there procedural causes behind that, or is this a professional, lack of desire to attend to that situation?
I think that's a really good question, Kylie, and I think that the answer is both. There's procedural restrictions in the guidelines related to verification of death. That's not standardised across the board and is a common issue that arises when, particularly for expected deaths, if the police are called and the bereavement of the family is really hindered upon that. But I think also it's an identity within paramedics, whether they perceive themselves as being responsible or able to stay on scene. Now, they may have restrictions through KPIs of, okay, you've got to be on scene for 20 minutes, then you've got to move on. But it might also be a personal expectation on themselves of, if I'm staying here, am I preventing myself from being able to respond to another emergency? So I think it's multifaceted and will take not only a change in guidelines, but also a recognition of identity within individual clinicians.
So it's really such an important part, isn't it, of the whole palliative care end of life.
Yeah, absolutely. And I take on board the learnings from my supervisors, and they've shared experiences of their own clinical, experiences around the verification of death process, particularly, and that being feedback that they received from family members that it was a really difficult and hard aspect of the care when police were called unnecessarily. So.
Well, thank you. There are a few comments in the chat, but they are all just essentially saying what wonderful piece of work or pieces of work that you have presented today, and I really appreciate all of that effort that's gone in, and yeah, just really excited to see where this leads to.
Thank you very much.
Thank you. And we will definitely hear from Madeline again later on if people have other questions coming up. For now, we want to move on and have a look at a new resource that has been developed for the PEPA program. And we've definitely noticed in PEPA over the last year or so that there's been quite an increase in the interest amongst the paramedicine workforce in palliative care. And we've seen dedicated workshops in a number of jurisdictions for groups of paramedics. And we've also seen an increase in paramedics doing PEPA placements in specialist palliative care settings. So that led us to realise, I guess, that the learning resources that we had available were not quite hitting the mark for paramedics. I guess one of the first people we had a conversation with was Madeline, given her recent work, and that also led us to engage with a group of very enthusiastic peer reviewers who, some of whom are here today in the webinar. And we were able to produce a learning guide for the PEPA program, which, if for those of you who don't know PEPA, it's a program of experience in the palliative approach and really focuses on ongoing education for the existing health workforce. And I wanted to just present that learning guide to you in brief today. It is only freshly released last week, so you may not have had a chance to see it. And then after that, we want to have a conversation about how we might be able to adapt and use the kind of learning content and activities in the PEPA module for the undergraduate cohort as well. So very much in keeping with Madeline's expertise, I think we have included in the learning guide the key content areas. That's essentially the philosophy and practice of palliative care. What is the paramedic's role in providing care, and how does that fit in with the broader healthcare team? Legal and ethical issues was a key area of learning need. Communication and symptom management as well. The learning guide supports learning, as I said, for placements and for workshops, or paramedics can just access the learning guide as a standalone CPD activity. We have them available in online. It's available online at the moment and will be soon available in print and PDF booklets as well. We've taken a case study approach, and as I go into the module, I'll introduce you to that. But we have found that embedding case studies in our learning activities is a better way for our learners to engage with and apply the learning. And as I said before, we had peer reviewed this learning content with 14 academic and clinical paramedic educators from across all jurisdictions. So one of the most engaged and enthusiastic group of peer reviewers that I've certainly worked with in these developing these resources. So really appreciate all of their input. So if you would like to, if you're already signed up and registered on our learning management system, you can go there now. Karen's going to put the link in the chat for us. And you can access the guide online. When you go into our learning management system and find the PEPA courses, it's just into learning guides, and then the learning guide for paramedics. And then you should just enter the course there. Just up front, we have a little intro to the learning guide so people can familiarize themselves with kind of how it's set up. So there's content, and we also have reflection activities, learning activities, links out to other resources, videos, websites, papers, etc. And then we have our case scenarios that are embedded throughout. The learning objectives are all spelled out here as well. And we really have looked at some of the situations in which paramedics frequently encounter people with palliative care needs, and using these kind of broad categories that are summarised in the literature as well. So we've kind of introduced people to that. So then we introduce our case scenario patients. People who have used PCC4U resources previously might be familiar with some of these case scenarios. They're the patient scenarios and video resources that we use in our core modules and focus topics. We've basically taken the stories from our current set of resources, and we've put an extension or an adaptation to it to bring in a paramedic encounter. So Michelle is a lady with end-stage breast cancer, terminal metastatic breast cancer, and we've entered a scenario where she is dying at home, and her husband has contacted paramedics as he's unhappy or worried about her pain relief, and her palliative care team is not contactable after hours. The family is aware that she's dying and she has her wishes clearly known, but essentially family calling for support. So we just got some images there and a bit of information about the case scenarios as well. I won't go through them all in detail, but just to say we have Herbert, who has end-stage heart failure. He's been in and out of hospital quite a bit, has called 000 with some difficulty breathing. Mary is a patient who's got cerebral palsy and now dementia, living in residential aged care, has had a fall and hit her head. She's got very clear instructions in her advanced care plan that she doesn't wish to go to hospital. And then finally, Alan and Betty. Betty is one of our case scenario patients who's got end-stage renal failure, and Alan cares for her. And Betty has unfortunately found Alan unresponsive in the toilet. So that's, I guess, that situation where there hasn't previously been any significant illness that's been talked about, but we've got acute deterioration. So that's our case scenario, patients. If you're starting to feel a little triggered by hearing all those stories and thinking about responding to that, just take a big deep breath, because we're not, what we do in our learning packages, we don't make you try and handle all that at once. We just weave the case scenario stories in through the content. So in terms of the communication content, we have used the SPIKES framework, which I know that many people are familiar with in paramedicine. And really a lot of the key instructions and then sort of examples of phrases, words and phrases that we can say have been provided by our peer review group. So they are, I guess, words that people use on a day-to-day basis, and it'd be really good as a development activity for people to be able to think about, you know, this is how you could say something like this. This is a phrase that can help explain X, Y, Z. So the case scenarios are there. They're also back in the ethical and legal issues, as you might imagine with those stories you heard. There's a few ethical and legal issues to confront there. We also have a section on emergency presentations. So essentially centered around what are the wishes and goals of the patient and their family, but including some key points about, you know, managing acute severe pain. And these are all based around the recommendations in the therapeutic guidelines for palliative care. Interestingly, we've included a whole section on after death care, so as we recognise that was one of the key learning needs as well. In particular, information about verifying death, when to call police, those kinds of things are covered in here in detail. And just finally, we have a section also at the end with some recommended apps and websites that might be helpful for people in their practice, and direct links there to download the apps. I invite Penny Neller to tell us a little bit more about the end-of-life law for clinicians resources. We have in our learning guide, we've linked directly to a number of the modules that Penny will talk to you about. Thanks, Penny.
Thank you, Sharon. And that's very kind of you to say. Delighted to be here. And I just had a little sneak peek ahead to have a look at that section. It looks fantastic, and the whole module does, so very well done. Look, thanks everyone. As Sharon mentioned, I manage a national training program called End of Life Law for Clinicians. This project started about 5 years ago. We kicked off with 10 modules about the law relating to end-of-life decision-making in Australia. In recent years, we've tailored the modules and added some new modules. The modules are now tailored so that they're also applicable to paramedics and nurses, and not just doctors, and also allied health professionals. So we now have 11 modules. They're about 30 to 60 minutes each. They contain a brief overview of the law on some critical areas. Those are outlined there. Most of those are in fact relevant to paramedics, and we have included resources for paramedics and also paramedic case studies throughout. I'll mention a couple of modules that would be of particular interest, I believe, to paramedics. So the first, the role of law in end-of-life care, which sort of gives an overview about this legal role that paramedics do perform as part of their everyday work. That might be interpreting advanced care directives, for example, or determining who a person's substitute decision maker is. Also, substitute decision making will take you through who the decision makers are in your jurisdiction, and obviously areas such as emergency treatment and providing pain relief are also very relevant. We've included a bit of content for paramedics in our module on voluntary assisted dying, because obviously that's an area that's it will increasingly become an end-of-life option in each state. And shortly we'll be introducing a new module, so that's going to launch at the end of September, and that gives an overview of some of the legal considerations when caring for individuals and families and communities, people from different Aboriginal and Torres Strait Islander cultures. So as I mentioned, you can get CPD for undertaking the modules. And I think the QAS is looking at implementing these modules in their learning management system. So we've been delighted to see that and to see the level of interest from paramedics. If you would like to do the course, you can actually access that through the same learning management system as PCC4U and PEPA. But the link is there, and you just need to enrol for the Allied and Other Health Professionals course. Resource at this website, which is End of Life Law in Australia. Our ELK modules link out to this website, and it gives a more comprehensive discussion about the law in each state and territory. So if you want to know who the hierarchy of substitute decision makers is in, say, Victoria, you can go to this website and pull that up immediately. So I'd encourage you to have a look at that one as well.
So with the time we have left now in this webinar session, we wanted to really just open up the floor to have a conversation about these kind of three issues that you can see on screen there. That what are the current resources that you're using in education for undergraduates or entry to practice paramedicine? What are you using to teach palliative care? Thinking about the PEPA resource that we've looked at, what kind of adaptations do you think might be helpful to use that resource? And then finally, what sort of educator support would be helpful? I guess part of the PCC4U project, part of our brief is to support educators in implementing education resources as well as providing some the education resources.
I think it's really important in the undergraduate curriculum. I find it very interesting that some services have specialists. I worry that they're metrocentric because in Queensland, we have 50% of our population living outside the capital city, and that 50% would be underserviced with a specialist model. So I'm all for raising the bar for what baseline paramedics can do in this space. And that goes to having good educational products and good service guidelines. And what I'm very interested in actually is, and Madeline may be able to answer whether this has been done, like a time series study where we look at people that were transported to hospital that had palliative care needs, and before protocols and guidelines were changed, and the number that have been transported to hospital now, or finding other resources within the community. I think that'd be very interesting. But until we skill people up to do the baseline care, inappropriate transports to hospital will still continue. In our program, we've introduced palliative care into one of our medical modules, and students now will spend 2 weeks looking at palliative care and how it intersects with paramedicine. So we're at the beginning, we use a lot of the PCC4U modules, and this new module looks great, and we'll incorporate it across our program into legal, into our emergency response subjects. We'll divide it up. So I guess that's my comments on this today.
Thank you, Nigel. I did put you on the spot. Nigel's coming to us from USC, so I've worked with him before. I think that's one of the other things that Madeline actually brought up was around the role of paramedics and their nature of being quite an independent health professional. And in the undergraduate setting, that need to perhaps expand on some of those multidisciplinary team activities in an IPL situation. I'm wondering, IPL is a buzzword across many disciplines and curricula. I'm wondering if you guys, Madeline or anyone else has some thoughts on how that might be incorporated.
So I wholeheartedly agree with Nigel in his remarks around the importance of ensuring there's a generalist capability, not just relegating it to the specialists' services, because as you said, ECPs sometimes are only available in those metropolitan areas and for limited time periods. So we're all about ensuring that there's a generalist capability, but with specialists perhaps options where available or desired. Now, Kylie, your comments around IPL, there are some universities that I'm aware of that are embedding I guess, placements in alternative areas for paramedic students to go and then experience the care settings other than just pre-hospital environment. And I know that that's been done really well in aged care settings, but I think that there's a huge opportunity to also extend that to palliative care settings, both in community and then also inpatient units as well. There's been some publications coming out of the aged care settings, increasing morale amongst the students to then take on geriatric patients and have a confidence to be able to deal particularly with complex diseases such as dementia. And I can see there being such a huge opportunity for that in the palliative care space as well.
In terms of, so we've got the PEPA content there. Do you think that there's anything unique in terms of how undergraduate paramedic students learn or how they would respond to this content how we could then present this PCC4U adaptation? It's probably something out for the educators and academics. I don't know if Madeline, if you've got any thoughts on that initially. You know, we've got that content sitting there, the case scenarios. Is there anything else that I think in the undergraduate setting, actually, I'm going to put Stephen, you on the spot here. There was some conversations around perhaps some audio of calls to
Yeah, this is something we're going to look at incorporating. So every year we go over to the Medical Engineering Research Facility over at Prince Charles, which we tend to use for skills, but I think there's a great opportunity to incorporate some of this activity, not just in regards to death, palliative care, but death and dying, because for many students, it'll be their first time with a cadaver. And I think it's a good opportunity for us to discuss some of that great work that Madeline, that you've done in a relatively controlled and supported setting. So that's where we were going with that. I haven't had a chance to listen to the audio.
Yeah, we're talking about the fact that, I mean, some of our case scenarios, I mean, we've given a text-based sort of continuation of the scenario, but perhaps hearing that voice of the person or their loved one ringing in, asking for that support, and for a paramedic then to hear that sort of situation and being further immersed in the case scenario. That was one of the things that potentially we would work with you guys to further develop.
Yeah, and I think it's going to be great. And I think I open up this invitation to anybody. If you're around, it's kind of around about the Prince Charles between the 4th and the 7th of October, and anybody wants to come down for a session, I'd be very open to come down and be really interested to get your feedback around about anything. And if that's something that just email me. I'll put my email in the wee chat box if that's something that people might be interested in. I'd be really keen to get feedback because this is the first time we're incorporating something like this. So you're never quite sure how it will go.
Fantastic. Thanks, Stephen. Nigel, you've got your hand up there.
Yeah, I think Madeline was before me, but I'm happy to go. I think some podcasts of lived experiences from people that have had significant others that have died and their palliative care journey, good or bad, and often we can learn from the bad ones. And I guess my whole issue is with it around paramedicine is the almost opportunistic points of care that we have when you're transporting someone for whatever reason, and you ask yourself, you ask yourself the question, would I be surprised if they died within 12 months? They're the people that need palliative care, not right at the end of life. And I think that still is an issue in paramedicine, is recognizing the value we can add to getting people in contact with palliative care services very early on. So they probably will live longer and better if we do.
Yeah, right. There's quite a privileged time points that you do have with them when often, you're waiting in the back of that van. It's quite intimate time, actually. Thank you. Madeline, sorry.
Yeah, to add on to what Nigel was just saying, I think a task around identifying referral pathways within jurisdictions and then within services or areas that the student is doing a placement in would be really useful. I also think that conversational prompts and perhaps dialogues where you can choose to go away and then see how that conversation would end up and then go the other way. It could be a really good mechanism for teaching students that there's not necessarily always a right thing to say, and that it can get sticky, but you can get out of the sticky question or the sticky conversation and reroute it back to somewhere that everybody is comfortable. I also think, though, that there were a lot of remarks made in our qualitative interviews from paramedics around then their expectation that actually they feel as though palliative and end-of-life care is at a point where perhaps mental health for paramedics was 10 to 15 years ago, and that it was introducing mental health education for paramedic students was quite seen as difficult to begin with and very soft skills focused, which is the contrary for what paramedics perhaps perceive themselves as being. But those soft skills will ultimately allow them to have those harder skills down the track.
Sounds like, Madeline, what you're describing is almost a simulation with a sort of range of rubrics and pathways that perhaps might be something that we could consider in the future developing, perhaps.
I realised that I forgot to share this other slide, and I might just take an opportunity to do that. We have done some work in terms of mapping the current PCC4U content against the professional capabilities for paramedics and the code of conduct. This is just the first page of it here on the screen, so there's more. If you go to that Padlet link, you can find the whole resource, so we're more than happy to email it to you if you'd like to see it. It's, I guess, preliminary at the moment, but in terms of mapping some of the elements of the professional capabilities and where we have content already in our courses that can meet some of those capabilities. And I know, Stephen, you were interested in this previously. We do acknowledge that, while, as we've said before, that some of our core modules being in the format that they're not exactly written for a paramedic audience, but some of those adaptations we might be able to make based on our work with the Pepper Learning Guide might be able to add in resources into those sections that strengthen the content for paramedicine. So I will stop sharing that point and let you get back to the conversation.
Thank you, Sharon. You popped up the messages. We acknowledge. I mean, I think, thank you so much, Madeline, for your presentation. And this is so timely. And I'm really, 10 minutes was just not enough to hear your work. Sorry. But just a taster. I'm really looking forward to see where this is going, and love a good framework. So very much looking forward to where this is going to be going. And we would look forward to working with all of you into the future. We've got these resources that are available, and we, I think hopefully this shows the approach that we've taken to the development of all of our resources is really partnering with educators, experts in the field as well, to ensure that these are of a high quality rigor and they're available at no cost. Because we're funded to support you and the students that are going to be getting these resources. Next webinar feedback, that'd be great if you can give us a bit of feedback around this one. It's always nice to be able to see how everyone is responding to these feedback or these webinar sessions. And if you'd like to join us for the next webinar, the 20th of September, and we will be focusing on simulation at that point in time. So it'd be great if you guys could join us then. But yeah, don't be a stranger, and I think we'll continue this conversation.
Wonderful. I think everyone's finished with that poll, so we might let you all go. Thank you so much for coming along.